Hello, students. Hello, good evening, all of you. From where we are streaming, there would be some lag. So, can anybody tell me if I am visible to all and I am audible to all? Yeah, I think we are. Uh, yeah, can somebody also type in the chat box so that I know that the chat box function is also working properly? And am I audible to all and am I visible to all? Yes. Okay. So welcome all of you. Welcome. Yes. Thank you all of you. Can I just have somebody typing in the chat box so that I know that the chat box is also working? And thank you all of you for coming in. We'll just start in a minute. Can somebody just put hello or OG in the chat box? Okay. Yes. Okay. Thank you, Utkarsh. Thank you, Naeem. Yes. Yes, Utkarsh. Yes, and Ankit. Yes, we thank you, Hanikit. Visible to all, and thank you, Utkarsh. Yes. Okay. So welcome all of you to the session. Let's have a rocking time. I'm the OG Guru, Dr. Punit Bhojani, and before this is the most important session where we are going to discuss the important MCQs. As all of you can see, the most important Virgin MCQs also and previous year MCQs also. Welcome all of you to the chat, and I want all of you to answer in the chat box. Right, wrong, koi problem nahi hai. If you make a mistake, it's fine. Better to be wrong over here than to be wrong in the examination. Only thing, from where we are streaming, there might be slightly a lag of 5 to 10 seconds. Okay. So, and all of you, I want of all of you to participate. But before we begin, just one thing quickly, all of you, please start following me on Insta. All of you also do subscribe to the YouTube channel, share this video with your friend, and also you can join on Telegram where the annotated PDF of this will also be showing. So all those who are not already following me on Insta can do that. Yeah, thank you, Dr. Shubham Sikdar, for your appreciation. Yes, okay. So all of you can also start following me on Insta, where we are posting daily MCQs. And last thing before I begin, do not forget to download the OG Guru app. This is the link for the Android and the iOS. And for iOS, put this code, and all of you can go for the rapid revision. There is still around 2 weeks for the NEET PG examination. You can call me on this number. I am personally guiding all the students how to study, how to prepare, and all of you can just go for the rapid revision where I just need 1 day of your time. In 1 day of your time, in rupees 448, you will be able to revise entire OBGY through MCQ discussion. Okay, so definitely do get in. You can download the OG Guru app and get in touch with me whenever you require for your timetable and guidance. Okay, so with this, let us begin, and I want all of you to participate. Yes, the first very important MCQ: 25-year-old patient cohabitating, that means living with the husband since 6 months, brought to the OPD by mother-in-law. Okay, सास भी कभी बहू थी. Okay, so mother has brought the daughter-in-law. Next step, what would you do? Okay. Okay. Thank you, Dr. Sham. Thank you for beta. Even for FMG all questions, but even for NEET PG, all questions will also come from my lectures only. Hoping for the same. Okay. Yes. Okay. Yes. Chalo. Anybody with the answer key? Okay. Please type the answer in the chat box. Right, wrong does not matter. All of you quickly type. Okay. Yes. Okay, C. Very good, very good. So please understand this. This is again a P. This has been asked and very likely to be repeated. This is a PYQ. Why? Because here all of you should know what is the definition of infertility. Since they are married only since 6 months, they are not a patient. All these are the investigations we do for the infertile couple. Okay, and when the couple is infertile, I would like to do HSG for tubes and the semen analysis for the male partner, because definition of infertility, very good, that sir, if there is regular unprotected intercourse, unable to conceive after 1 year. So this couple is not your patient. You just have to tell them what? Relax. Okay, because वो खाली I jokingly tell all my students and my patient कि वो खाली एकता कपूर के सीरियल में होता है और हिंदी पिक्चर में होता है कि हीरो हीरोइन मीट, हीरोइन pregnant in the first shot itself. Okay, so it's not going to happen. If they haven't conceived in 6 months, what will you tell them? Relax. Meditation, yoga se hoga. Okay, so reassurance is the answer over here. Nothing needs to be done. But can anybody tell me, as a good doctor, what one more thing we can start for the patient? Anybody? एक हम tablet start कर सकते हैं. Reassurance, yes, definitely. So reassurance is the answer. Okay. You are going to have a lot of fun time today. We are going to discuss all the previous years important question. Clinical cases will also come. As you could see, this is a clinical case. Image based questions are also going to come. So stay right till the very end, and lots of MCQs we are going to discuss in the upcoming 2.5 hours time. Anybody? Yes. What is the answer? Answer is yes, but what else can be done? Thank you, Bhanu Pratap, for your yes. Very good, Bishal Devnath. Okay, sir, we can start folic acid supplementation. The reason being that folic acid, very good, Sabina, folic acid. Why? Because we require folic acid is in the periconceptional period. Okay, before planning a pregnancy, an entire first trimester, periconceptional folic acid. Even this has been asked for prevention of neural tube defect, for neural tube defect prevention. Okay, students, so mainly important is reassurance. You just tell them to relax, there's nothing to worry. And after 12 months, okay, suppose they tell you that 12 months have already passed, then you start the investigation. Then we start the investigation for the male and the female partner together, and in that case then the answer would be semen and HSG and all that. Okay, so reassurance plus folic acid is what is required, and explain to them about the fertile period. Okay, yes. Now very important short MCQ aane hi wala hai. Yes, all of you. 28-year-old first clinical case hai. I want the diagnosis. I want all of you with the diagnosis. 28-year-old, married since 4 years, irregular periods. What are the complaints? Complaints of irregular periods, acne, hirsutism, infertility, partner investigation normal. Anybody? What is the diagnosis based on the history so far given to you? Very good, all of you. Evangel Nagarajan, yes, Akshana, yes, excellent, Zach. Okay, so this all of you know are the symptoms or picture of PCOS, because irregular periods, acne, hirsutism and infertility. Now anybody with the answer A, B, C, D, kya karna hai? Short this MCQ, why is going to come? Anybody, can you tell me one word answer? Why is the patient of PCOS infertile? In PCOS, why is there infertility? Anybody? Why is there infertility? Why is there infertility in PCOS? So infertility is because of what? That if you know, yes, sir, infertility is because of an ovulation, and therefore whenever the patient is infertile, we have to give ovulation induction medicine. I hope this is absolutely crystal clear to all of you. Okay, sir, over here, OC pills will not be acting. OC pills is birth control, and when you give OC pills, I'm teaching you picture abhi baki hai mere dost in 5 minutes. So point number 1, sir, since there is infertility and partner investigations are normal, we have to go for ovulation induction. And very good, as per the latest guidelines, please understand, clomiphene citrate was the drug of choice, many years back after 2018-19, and therefore this MCQ is coming for sure. Letrozole is now the first drug of choice. Is this understood to all of you? And therefore the answer is letrozole and not clomiphene citrate. And anybody, can you tell me what is this HMG? HMG is human menopausal gonadotropin. How do we get it? This is a injection. These are injections. This is from the urine of the postmenopausal lady. Okay, that is given when the oral medicines fail. Okay, so OC pills is not going to act over here, and therefore the answer is letrozole. Is this understood to all of you? Can I get 5 thumbs up? Then I will proceed further. Basically, one word answer, infertility hai, ovulation induction, and the number 1 drug of choice, letrozole. Letrozole is the first drug of choice. Yes, very good, very good. First drug of choice. Yes, human menopausal gonadotropin from the urine of the postmenopausal lady. We're going to discuss that also, because in postmenopause FSH is going to be very high. We'll discuss that in the upcoming MCQs. Now, can anybody tell me similar MCQ ye wala? Next MCQ, 20-year-old lady comes to us with treatment for hirsutism. Again, obesity, acne, irregular periods, FSH देखो कितना दिया है, LH, testosterone elevated. Such a big MCQ. And what is the answer? So all these are important clinical case scenarios. Anybody? Yes, that, sir, here please understand again, our diagnosis is PCOS because of the clinical features of hirsutism, acne, irregular periods, and look at the FSH to LH ratio. Okay, FSH to LH ratio over here. Anybody, what is the normal ratio of FSH to LH? So with one clap if you feel happy. With one MCQ we are discussing multiple MCQs. हम ये एक ही क्वेश्चन आंसर नहीं कर रहे हैं. FSH to LH normal ratio 2:1, and in PCOS what can happen? The ratio will become inverted, ulta 1:2 or 1:3 or even 1:4, which is the, यहाँ पे देखो 1:4 है, because FSH is 9, LH is 36. Yes. And what is the most appropriate treatment? Very good. Clomiphene citrate, never for a young unmarried girl. Similarly, letrozole nahi. All this is only when the patient is infertile. And ovarian drilling is also almost a outdated surgery. Hardly ever we do it, but that's again when the patient is only infertile. And very good, the answer is oral contraceptive pills. Perfectly correct. Why oral contraceptive pills? And anybody specifically, which oral contraceptive pills can we give? Which oral contraceptive pills? So here we will remember that, sir, when the patient is wanting treatment for infertility, or when she wants treatment for acne, hirsutism, and irregular periods, then what are we going to give her? OC pills. Is this understood to all of you? Yes. And therefore remember, Therefore, remember, clap if you feel happy. Naam mein hi, and why occipils? Because sir, occipils will make the periods regular, and acne hirsutism will also become lesser. Occipils will decrease the acne, decrease the hirsutism, and therefore yes, and therefore clap if you feel happy. नाम में ही आंसर है, नाम में ही आंसर है PCO, उल्टा कर देंगे OCP, ठोको ताली। PCO OCP का मतलब क्या है कि सर पॉलीसिस्टिक ओवरी ओरल कॉन्ट्रासेप्टिव पिल, जस्ट इनवर्ट। Okay, very good, Shubham. Specifically the one which contains, yes, either which contains cyproteron or drospirenone. This is a next level. Okay, 2027 MCQ. Okay, drospirenone. Okay, drospirenone. Why? Because both these have anti-androgenic property. Okay, these have got cyproteron and drospirenone containing occipil because they have got anti-androgenic property. Okay, is this understood to all of you? So please remember what the questions, and that's why both questions I have selected. Don't get confused. I quickly repeat, in the previous question, the patient had infertility and therefore the answer is letrozole and not occipil. And here, since the patient wants treatment for acne and hirsutism, I have to go for occipils. Okay. PCO OCP. Okay, is this understood to all of you? So I hope all of you like this PCO OCP ka, and clap if you have learned something new. Okay, moving on to the next. Again, short MCQ. Girl is brought to the OPD by mother, not yet attended menarche. Which of the following will now indicate primary amenorrhea? Again, sure MCQ, because the definition of primary amenorrhea has changed. So anybody, do you know the new definition of primary amenorrhea? Yes, I want all of you to answer in the chat box. Right, wrong does not matter. We are here to learn from the mistake, because if you better to be wrong over here than to be wrong in the examination. Okay. Yes, C, D, A, B, C, D, A, B, C, D. Okay, yes. So now please understand very quickly that the primary amenorrhea definition has changed. The old definition was that, sir, if by the age of 14 years, all of us know thelarchy, pubarchy, menarche. That means the breast development, then axillary pubic hair development, and then menses. This is called as secondary sexual characters, SSC I am writing. Okay, so when the girl is 14 years old and there is no secondary sexual characters, I would label her as primary amenorrhea. But if the secondary sexual characters are present, then I can wait for 2 more years and we would label the girl as 16 years. But please, my dear student, this is the old definition which we are no longer supposed to follow. And as per the new definition, 1 year we have decreased lesser, and therefore 13 years and 15 years is what we need to remember. Is this understood? Yes, all of you, excellent. So now when you go back, 14-year-old, no menses with breast development, no. 13-year-old, no menses but with breast development is present. Again, this is not, because here I can wait till 15 years, isn't it? Because with breast development hai. And 13-year-old, no menses without breast development. Very good. All those who typed C in the chat box, clap for yourself. C is the correct answer. Don't worry if you have got it wrong. 14-year-old, no menses without breast development. This is the old definition, old criteria. Is this clear? That's why many of you marked it as D is wrong. Sahi answer is C. Okay, so 14 and 16 you are not supposed to look. Just remember 13 and 15 in the entrance paper and mark it correctly. Is this understood to all of you? Yes. Now, anybody, what short MCQ? Again, this is a clinical case-based scenario. Okay. Clinical case-based scenario. 16-year-old present with primary amenorrhea. Breast is well developed and the clue absence of axillary and pubic hair, lump felt in the inguinal region. USG reveals absent uterus. The diagnosis. Short question ये है. Yes, yes, superb, all of you superb. Yes, Black Camp, Apanna, Shubham, Riptara, Angela Zakir. Yes. So now please understand this, why this is important, because in whole of OBGY, in whole of Gynac, if you get a combination of primary amenorrhea plus absent uterus, can anybody tell me what are the only two options? I repeat, primary amenorrhea, absent uterus, it is only two possibilities in the whole of gynecology, RMKH, and second is androgen insensitivity, also called as testicular feminization syndrome. Okay, is this understood to all of you? So don't even look at option C, option 4, okay, because Turner syndrome, Kalman syndrome will discuss in some time, in that the youth. So ये आपको देखना ही नहीं है. Yes, and the clue, how do I differentiate between the two? Okay, karyotyping भी आपको बता देंगे. Breast, anybody? Breast is well developed in both of them. That is not the difference. We are supposed to look at the axillary and pubic hair, because axillary and pubic hair are androgen dependent. In RMKH there will be well developed axillary pubic hair, and here it is going to be absence of axillary pubic hair or sparse. And since over here it is absence, very good, the answer is androgen insensitivity syndrome. And anybody, can you tell me what is this lump in the inguinal region? What is the lump in the inguinal region? What is the lump in the inguinal region? Lump in the inguinal region क्या है? Anybody in this patient? Very good. So these are the undescended testes. Okay, testes have not descended, and therefore they are the undescended testes, which we will remove. Okay, which we will remove. Okay, so lump in it. And suppose in the same MCQ you get primary amenorrhea, absent uterus, but if they tell you well developed axillary pubic hair, then please mark RMKH as the answer. Is this understood to all of you? So please don't make a mistake in this, and I hope all of you get this correct. Okay, yes, moving on to the next MCQ. Now tell me again the diagnosis. 16-year-old primary amenorrhea. Why I'm talking primary amenorrhea? 3 MCQs because short stature, shield shaped chest. What is the diagnosis? Very simple MCQ. Very good, all of you, very good. This is your Turner syndrome. This is the Turner syndrome, and therefore Turner syndrome 45XO is the karyotyping. This is Turner syndrome. Now please understand this, that Turner syndrome, absent uterus, undescended testes तो किसमें था अभी बता दिया. And anybody, which condition do I get absent uterus? Normal ovary. Anybody? Yes. Okay, sir, in Turner syndrome, there is streak ovaries. Ovaries are replaced, because basically non-functioning ovaries are replaced by fibrous band. But please remember, it is not absent uterus. टर्नर सिंड्रोम में यूट्रस होता है लेकिन छोटा होता है, चिंटू यूट्रस. ओके, चिंटू, बिकॉज uterus requires estrogen for its growth, isn't it? Sir, uterus requires estrogen for its growth. and estrogen comes from the ovary, and ovary is not functioning in Turner's, and therefore in Turner's syndrome the uterus is hypoplastic. But remember, my dear student, it is not absent. So absent uterus, streak ovary is not possible in any of the condition. Very good, all of you. I'm so happy. Streak ovaries and hypoplastic uterus is the this. Perfectly correct. Normal ovaries, RMKH syndrome, and absent uterus, undescended testes. I told you, complete androgen insensitivity syndrome. Clap if you are enjoying. Clap if you are getting lot of knowledge. Clap if you are learning constantly new things. Okay, is this clear to all of you? So option B is the answer, streak ovaries. And as I said, do not forget to download the app. Also, do not forget to subscribe to the YouTube channel, and do get in touch with me for your timetable and guidance and how to study further for your upcoming examinations. Okay, yes. Now moving on, new style of question which is again surely going to come, and that is the match the column. Okay, and these questions are going to come, and don't get confused because you get lot of options and then you get confused. Okay, so Turner's syndrome, already I told you, is 45XO. 45XO is Turner's syndrome. Anybody? So 1A. Okay, so 1A, 1A. So automatically your two options are ruled out. Two options are ruled out. Is this clear to all of you? Yes. RMKH is a proper female 46XX. So 2C, 2C. And AIS, I told you testes are present. So that is XY. Very good. So 3B. 3 के साथ B आ रहा है, and very good Klinefelter, all of you. 47XXY, and therefore all of you excellent students, excellent. B is the answer. 1A है लेकिन 2B नहीं है, 2 के साथ 3 है, and 4E नहीं है. Okay, so this is out, this is out, this is out. Absolutely correct. 4M, again clap if you feel happy with this one question. I have covered 4 MCQs. Okay, 4 MCQs in this one MCQ. Okay, is it absolutely crystal clear to all of you? Yes. Okay, let us go on quickly to the next level, next MCQ. Now, yes, after some gynac, now moving on to obs, we'll keep on mixing. Gynac obs mix karte rahenge. All of the following screening test used in the second trimester for aneuploidy. Aneuploidy specifically, I mean for trisomy 21. Trisomy 21, except is the question. तीन चीज याद रखना है. And suppose if I give you one more option, amniocentesis, if I give you one more option also, okay, means if I just add, okay, I'll add later on so that there's no confusion right now. We'll add later on, but yes, excellent all of you. इसमें दो चीज याद रखना है. First word screening test, second trimester, and except. So very good. Anybody, what is the screening test which I do in the second trimester? उसके पहले very quickly, triple marker test. Anybody? Triple marker test is done when? Triple marker test, sir, is done in the second trimester. Triple marker test is done in the second trimester when? 16 to 18 weeks. Okay, 16 to 18 weeks is the time. Again, please remember this question, very important. What are the three components of triple marker test? HCG, alpha fetoprotein, and what? बेटा स्वीटी एक मिस्टेक कर दिया, एक मिस्टेक. ओके, वाई? बिकॉज क्लैप इफ यू फील हैप्पी. नो स्वीटी, नॉट 12 वीक बेटा, ट्रिपल मार्कर. वेरी गुड. मिथुला, ट्रिपल मार्कर टेस्ट डन एट 16 to 18 वीक्स. ओके, नाउ कैसा ट्रिक याद रखना है? क्लैप इफ यू फील हैप्पी, ट्रिक क्या याद रखना है कि यहाँ पे ट्रिपल मार्कर टेस्ट, ट्रिपल मीन्स 3 and therefore here also 3 will come, which is your unconjugated, yes, estriol, estriol, not estradiol. Okay, is this understood to all of you? And now can anybody tell me, suppose if the baby has trisomy 21 or Down syndrome, what is going to be up and what is going to be down? Anybody? क्या बढ़ेगा क्या कम होगा? So in Down syndrome, HCG arrow up and other two arrow down. Okay, other two arrow down. And similarly, if I tell you quadruple marker test has got extra which thing? Quadruple marker test has got inhibin A. Quadruple marker test is inhibin A. And no, not all up beta, not, yeah, no problem beta. Yes, HCG arrow up, other two arrow down. इसके ऊपर भी एक MCQ है. And inhibin A is higher than normal. So all of you please understand this MCQ. Yes sir, HCG is done in the second trimester. Alpha fetoprotein, inhibin A. Answer all those who said option A correct, because PAP A is done in the first trimester. Is this understood to all of you? HCG is also done in the first trimester, but that's not the best answer to mark. Why? Because please understand that HCG is done in the second trimester also. PAP A is done only in the first trimester as a part of our dual marker test. Okay, dual marker test. PAP A is pregnancy associated plasma protein A. Is this understood to all of you? And don't get confused, screening test. And now anybody tell me which is the confirmatory test? Which is the confirmatory test? Which is the confirmatory test? The confirmatory test is very good. KK, which is your very good? Yes, 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 yes. No, beta, fetus cell, yes. So the confirmatory test is your karyotyping. Okay, screening test is this, and the confirmatory test is the karyotyping, which we can come to know only by doing amniocentesis or chorionic villus sampling. Yes, very good, Soumyadev, very good, Zakir Khan. Excellent. So PAP A is a part of dual marker test. Dual marker test is HCG and PAP A. PAPPA. So HCG दोनों में है. Okay, they can also ask you which hormone is used in dual marker and triple marker test. So HCG. Okay, so all are used in second trimester except, so HCG. Why is not the answer? Because sir, HCG is used in the second trimester, is in first also. PAP A is only in the first trimester. Okay, now very simple. All of you know the arrows and therefore short. Chalo. Now this all of you should know. Next MCQ सबको correct आना चाहिए. Anybody? Which of the following is not true for antenatal trisomy 21 screening? Okay. So yes, we just now discussed and we know that sir, PAP A is going to be lesser than normal. Alpha fetoprotein is also going to be less. What is the NT scan? We are going to discuss now. NT, yes, is higher than normal, and answer is option number C. Very good. Decrease in HCG, because sir, HCG is going to be higher. Look at the arrows. Even in your triple marker HCG high tha, quadruple marker HCG high tha, even in dual marker also HCG is higher. PAP A is lower than normal. Okay, so please don't make a mistake. I hope all of you know the full form. PAP A, pregnancy associated plasma protein A. Okay, pregnancy associated plasma protein A. And anybody, what is this NT scan? What is the NT? And how much is the value for NT? How much is the value for NT? Yes, anybody, how much is the value for NT? So what is the NT scan, and when is the NT scan done is also one of the MCQ which is going to come up in some time. So anybody, NT का क्या value है? Yes, okay. So NT matlab at the nape of the neck, nuchal translucency we are going to check, and this is of course a radiology MCQ but also comes in your gynac, and this is, okay sir, the baby is like this, and can anybody, and this is like this, and then the baby is like this. Okay, this is how the baby looks, and this umbilical cord. We have to zoom in this part, and क्या होता है? Can anybody tell me? Yes, very good. And one more thing, nowadays we measure. My students will know it. Okay, short, difficult. Virgin MCQ, next level 2026 MCQ. So NT is a space at the nape of the neck. We put the caliper here, we put the caliper here, and we mark the NT. Very good. Up to 3 millimeter is considered normal. So the NT value should be like say 1 millimeter, 2 millimeter, 1.5 millimeter. All that is considered normal. If it is more than 3 millimeter, some say 3.5, but up to 3 millimeter is normal. Very good. More than 3 millimeter is this. And anybody, new thing, something new over here. Why we call it as NBNT scan? Anybody, what is this NBNT scan? NBNT scan क्या है? Clap if you have learned something new. Yes, sir, nasal bone. We also check for nasal bone because absent nasal bone. Okay, absent nasal bone is also one of the ultrasonography features of trisomy 21. Okay, very good Sabina, very good Soumyadeep, excellent, all of you doing very well, and don't be afraid. I want all of you to answer right, wrong, nothing matters. Okay, yes, when to do NT scan we'll also discuss in some time. So this is the answer over here. NT will be more, HCG will not be lesser. Moving on, as per the latest criteria, BPP includes which of the following? Anybody, what is BPP? Question is modified BPP. What is BPP? It is whose score? And quickly all of you, please share the link and tell all your friends that we are live. It's a very important session. Still there's a lot of time left and lots of MCQs, so quickly share the link with all your close colleagues. I'll give you 5-10 seconds time. Quickly share this link with all your friends and put it in the group, and tell all your other friends also to join in for this live very interesting session so that all your friends can also benefit. Okay, and do share this video link with everybody so that other students can also benefit. Okay, so quickly please share with all your colleagues. We'll just give you 5-10 seconds time. Very good. Yes. So BPP is biophysical profile, also called as the Manning's score or the Manning's criteria. It is a test for fetal well-being, and totally we have 5 components, but modified BPP is done to save time. And yes, no, tone नहीं देखते हैं, tone is not there. AFI. See here they confuse you as per the latest criteria. So student get के कुछ latest है क्या नया? No. So NST and AFI. NST is non-stress test. AFI amniotic fluid index. This is the BPP, modified BPP. Okay, totally BPP has got 5 components. Can anybody quickly tell me what are the other components of BPP? When I look at BPP, when we look at BPP, BPP totally has got 5 criterias. What are the 5 criterias for BPP? NST is one of them. Fetal movements, okay, fetal tone, fetal breathing movements, I'm writing BM, and the amniotic fluid pocket. Okay, we just look at one pocket in this amniotic fluid pocket in one corner. Okay, at least in one amniotic fluid level in one corner, which is your all the 5 components. Okay, now anybody? Yes, correct. Very good, Pratyusha. Yes. So anybody, now my question to all of you is, and all of you know, that total score is 10. 10 means good because each component is given a score of 2 or 0. Now anybody, how is this fetal movement counted? If I ask you, who will count the fetal movement? Anybody, who will count this fetal movement? Mother, father, neighbor, intern, or none of the above? Chalo, I am so happy I teach this every year. I am giving you all this option. Okay, in BPP, who will count the fetal movement? Anybody? Option A, option B, option C, option D, option E. Yes, 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 yes. Yes, okay. So all those, quickly clap if you feel happy that sir, the mother counting the fetal movement is different. This is the AIMS MCQ I teach every year. Yes, very good. Okay, sir, ye fetal kick count. In fetal kick count, the mother counts the fetal movement and not in BPP, not the father, not the neighbor. Why neighbor should count? If neighbor is counting, definitely kuch to gadbad hai, and not the poor intern. Okay, intern has got lot of other work to do, study for NEET PG, okay, and attend lectures. So intern will not count the fetal movement. None of the above basically is the answer, because clap if you have learned something new, or smiley in the chat box. Okay, sir, here the radiologist. Very good, radiologist. And this looks like a joke, but this question has been asked. Okay, this question has been asked in the INICET recently. Okay, in the the option kya diya tha? All are components of BPP except, and the option was fetal kick count. No, so fetal kick count is different from fetal movements. Rightly said, all these components a radiologist or a sonologist on USG machine we will count. Okay, yes, excellent, all of you, excellent. Okay, so just keep in mind, when you say this fetal movement, don't say this fetal kick count. Okay, fetal kick count nahi batana hai. Yes, thank you hard worker S. Thank you for your love and appreciation. Quickly, jaldi, tell all your friends also to log in now and join the live session, or of course they can also see the recording version anytime whenever they are free. But if they join in live, that will be great fun. Yes, very important. Earliest diagnosis of live pregnancy is by. Chalo. So yes, radiologist is correct. Yes. Anybody? Earliest diagnosis of live pregnancy is by. Now, transvaginal sonography, UPT, TAS, transvaginal serum beta HCG. Okay, now yes, okay, Ankit and Sai, yes, okay, so googly question, please understand early. And if I change the question and if I make the diagnosis live हटा दिया तो क्या है? Okay, so please understand, in the whole world, when I want to detect pregnancy, okay, serum beta HCG is the first to become positive. Serum beta HCG is first to become positive, and that will tell me that the patient is pregnant. And then that blood levels keep on rising, and then the levels come in the urine, and only after serum beta HCG is positive, even before missed periods. Okay, is this understood to all of you? That's not the answer. Okay, yes, even before missed periods the serum beta HCG is positive, and then the levels rise, and then you get the UPT positive, urine pregnancy test. आपने देखा होगा that kit test, what you do, okay, we have to put 2 drops of urine over here, and then you get 1 line or your 2 lines. Okay, kabhi khushi kabhi gum. Okay, why kabhi khushi kabhi gum? Because if it's a planned pregnancy, very good. If it's unplanned pregnancy, shocking, then gum. Okay, so दो बूंद खुशी के, दो बूंद जवानी के, ऐसा. Okay, and whichever heroine conceives, they take her as the model for this UPT kit. Okay, yes, all of you know, many years back Shilpa Shetty was the model, then the next model was your Kareena Kapoor, and then now probably Anushka Sharma was the model. Now we don't know who is going to be the next model. Probably Katrina Kaif is going to be the next model, or we don't know. Okay, or Kiara Advani. Okay, yes, but the thing is, all this is to detect pregnancy. Please understand, yes, serum beta C positive and urine positive test only after missed periods. But all of you please understand that UPT is positive after missed periods. Very good. But यहाँ पे I want to know live. बेबी बोलता है जिंदा हूं मैं, जिंदा हूं. तो live के लिए we have to see fetal cardiac activity. Thak 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 thak. And therefore urine pregnancy test and serum beta HCG are not the answer over here. Is this understood to all of you? Because sir, in the whole world, for live pregnancy, I have to demonstrate the baby heartbeat, and that is by transvaginal sonography. Yes, very good. That sir, first we will see inside the uterus, we will see the gestational sac. Gestational sac is seen first as a proper circle. Inside the gestational sac we get one more circle, which is the yolk sac, and then attached to it you get the fetal pole. And then when we see the heartbeat flickering, thak 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 thak, fetal cardiac activity, that tells you that the baby is live. Is this understood to all of you? Thoko tali clap. Okay, so please understand this. And can anybody tell me how earliest? Yes, very good. Okay, so fetal cardiac activity, because the word important is live, and therefore UPT. See, beta HCG is just a number. Okay, suppose beta HCG is positive 500, 1000, 2000, 5000. How will it tell me it's a live or not? So whether the pregnancy is live, one baby, two baby, inside uterus, outside uterus, all that only on transvaginal first and then transabdominal later, after 1 week. Okay, all of you should know this, the after 1 week of TVS. Okay, after TVS 1 week ke baad transabdominal. Okay, so transvaginal sonography picks up heartbeat as early as 5.5 weeks or 6 weeks. Yeah, beta 4 weeks 5 days Akanksha is the gestational sac. Okay, gestational sac will come in as early as 4 weeks 5 days. Okay, 4 weeks 5 days on transvaginal. Okay, for the live heartbeat at least 5 weeks 5 days or 6 weeks. Okay, 5 weeks 5 days is what you can remember. Okay, is it clear? So keep in mind, earliest diagnosis of live pregnancy is by transvaginal sonography, because it can detect fetal cardiac activity. Short MCQ, to not make a mistake. Yes, moving on to again some gynac. So we are doing gynac-ops, and all those who haven't yet subscribed to the channel, YouTube, please subscribe to the channel and also start following me on Insta. Yes. Beta Pratusha, yes, you are got it correct, but apne typing mein, yes, TVS will be first and then TS. Yes, Ankit Yadav, very good. Okay, 5 weeks, 5 days to 6 weeks, trans abdominal, 1 week still later. Yes, so again, a very popular image-based MCQ, short coming. Till now it has not. Is this copper T? Why is this not a copper T? Is this a copper T? No, this is not a copper T because sir, in copper T, there would be a copper wire. यहाँ पे copper, यहाँ पे copper, यहाँ पे copper. Okay, and this is LNG, intrauterine device, also called as Mirena or LNG IUD. And please keep in mind that many students got this wrong. Again, it's a previous year question. Yes, very good. Okay, मिस्टेक क्या करते हैं स्टूडेंट्स के it is called as LNG20 and therefore all of them will mark option B. Is it? Option B is the answer? No, sir. Option B is not the answer because it is LNG intrauterine device or LNG20, also called as Mirena, because total quantity is 52 milligram. Then why do I call it 20? Because sir, 20 microgram is released per day. Is this understood to all of you? Yes, this is milligram and therefore that is not the answer. Okay, the question is what is the content and what is the total quantity. Total word nahi bhi diya hai to okay hai, but total quantity is 52 milligram. Matlab this hormonal barrel contains 52 milligram. If they ask you how much is released per day, 20 microgram is released per day, effective for yes. Very good. Excellent, all of you. Now, one more question regarding the same. What are all the benefits of this device? Very, very important. Apart from contraception, again a short question. Yes, anybody? All are the benefits of this except. Yes. Okay, so please understand this is going to release progesterone. And what are the main benefits? Anybody, what it does? Please understand that sir, it is going to continuously release progesterone. Yes or no? As all of you know, uske andar hai LNG20. LNG is a progesterone, and progesterone all of us know is counteracting estrogen. So can anybody tell me how this Mirena is helpful in treatment of heavy menstrual bleeding or menorrhagia? How it will help in treatment of menorrhagia? Anybody? I am telling you there's one more benefit which is the most important. It is used in management of menorrhagia. Anybody, how? So please understand what it does is that what is menses? Sir, normally only if the endometrium is growing, it will shed off in the form of menses. Yes or no? Now what does Mirena do? LNG IUD, it will not allow the estrogen to act. It is anti-estrogen. Progesterone counteracts estrogen, and for the lining of the uterus remains very, 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 very thin. It is like I tell all the students that sir, I will shave only if the beard is growing. If the beard is not growing only, Tiger Shroff, what will the person shave? Okay, so since the lining or the endometrium, basically endometrium in Mirena patients is going to remain very, very thin, and therefore Very good. It prevents the endometrium from growing, and therefore menses becomes scanty, and menses can even stop. Scanty flow, and there is amenorrhea, but this is very safe. This is progesterone induced amenorrhea. Okay, this is progesterone induced amenorrhea. Okay, is this clear to all of you? Okay, this is progesterone induced amenorrhea. Because of excessive progesterone there is amenorrhea. Yes, thank you for all your appreciation. So kaise karenge? Yes sir, of course it is useful in treatment of endometrial hyperplasia. It is for both prevention and treatment of endometrial hyperplasia. I can give it. It is going to reduce the dysmenorrhea in endometriosis, is also correct, because there's no menses only. Basically remember, when I put this Mirena, patient will become amenorrhea. Patient will have amenorrhea. It induces amenorrhea in the patient. ये याद रखो. And also, my dear student, remember this extremely important PG level point, कि sir, the cervical mucus will become thick. So if the cervical mucus becomes thick, pelvic inflammatory diseases are going to become lesser, and even ectopic pregnancy will become lesser. Okay, and therefore the answer is option number D, none of the above. Yes. So remember, four main uses we will remember, that sir, prevention and treatment of endometrial hyperplasia, protects against ectopic pregnancy, mainly menorrhagia, and dysmenorrhea will also become lesser, and similarly even endometrial cancer will also become lesser. Okay, and protects against ectopic is correct. Yes, Mirena will protect against ectopic pregnancy. Okay, so because the endometrium will remain very thin and cervical mucus will become thick. So if the cervical mucus becomes thick because of progesterone, PID episodes, it will decrease pelvic inflammatory disease, and therefore it will decrease ectopic pregnancy also. Okay, is this understood to all of you? Yes. Quickly, before I proceed further, I'm sure all of you, if those who are not following me on the Insta, every day I'm posting previous year question interesting reels. So please follow me on Insta, and of course all of you know the channel, share it with your friends, and also join the Telegram also. Okay, and when you are okay in this video also, please hit the like button, so that please hit the like button. Okay, and definitely download the OGGuru app. These are all the QR codes. Android app, iOS app are available, and I request all of you can just, because still there are 2 weeks for the exam, just go for the rapid revision MCQ discussion package. Within 1 day you will be able to revise all this MCQs, you will be, and many much more you will be able to revise within just 1 day time. Okay, so moving on to the, and please share this video with your friends and do hit the like button. Moving on, yes. Okay, ideal time to perform NT scan. Will not waste much time, because we have already discussed everything in detail about the NT scan just some time ago. Now tell me, when are we going to do the scan? Yes, not at 8 to 10 weeks time. The NT scan is going to be done at 11 to 13 weeks of gestation. Okay, is it clear? Because that is the time when you get the proper measurement, and all of us know 11 to 13 weeks is the time for the NT scan. Yes, all of you correct. Anybody, which is the sonography done between 18 to 20 weeks of gestation? 18 to 20 weeks with son. Yes, all of you correct. Yes. Okay, and as I said, please do share this link with all your friends and colleagues, and you can tell them to join in live or see the lectures whenever they are free. 18 to 20 weeks. चलो 18 to 20 weeks पे कौन सा सोनोग्राफी है? Yeah, Pratusha, amniocentesis we do at 16 to 18 weeks. I'm saying which sonography? Which sonography we do at 18 to 20 weeks? Because ये बात sonography का हो रहा है ना? Yes, excellent all of you. We do the anomaly scan. Remember, it's the single most important sonography of the whole pregnancy. Or yes, very good, people call it as TIFA scan also, targeted imaging for fetal anomaly. Okay, some call it TIFFA. Basically, anomaly scan or malformation scan. Remember, targeted imaging for fetal anomaly is done between 18 to 20 weeks of gestation. Okay, so I hope all of you get this correct. Do not make a mistake. Extremely important MCQ surely coming. Patient has come to the hospital with septum in the uterus. Septate in the uterus. Septum in the uterus. What is the management of this condition? Anybody? A, B, C, D. And can anybody tell me whether we choose laparoscopy or hysteroscopy? Yes, yes, very good, very good. Yes, very good. Yes, so please understand, why not laparoscopy? Why not laparoscopy? Anybody? Why I will not do laparoscopy surgery? Because sir, in a septate uterus, laparoscopy is normal. Please understand this, very very important. Okay, sir, septate uterus is a condition where the septum is projecting into the uterine cavity. Yes. So yeah, basically it's a septate uterus. It's not a vaginal septum, Pratyusha. The question is septum inside the uterus. Okay, the question is septum in the uterus. Yes, vaginal septum is different. Okay, Pratyusha, don't get confused. Transverse vaginal septum, separate condition. This is the septate uterus which is there. So please understand this, that when we do a laparoscopy, we put in a telescope from above and we are looking at the outer surface of the uterus. Laparoscopy also I am going to teach you in the upcoming hour. So please understand this, laparoscopy is going to be normal. In a patient of septate uterus, laparoscopy is normal. Laparoscopy is no role. Similarly, no point doing laparotomy and no point doing laparoscopy again. Yes, because the septum is within the uterus, and therefore all of you correct that sir, I am going to put the telescope inside the uterus and we are going to do hysteroscopy. Hysteroscopy is to visualize the cavity of the uterus, and we are going to cut the septum from inside. You will keep on cutting the septum like this, like this, like this, and all of you can see how we are cutting the septum like this, like this, like this, like this, like this, like this. You cut, and therefore this surgery which we do is called as laparoscopic, hysteroscopic septal resection. Okay, septal resection, or also called as hysteroscopic metroplasty, and not laparoscopy. Okay, so hysteroscopic septum cutting, or cutting the septum. Okay, and therefore septoplasty is the word used, or septal resection. Is this understood to all of you? Yes or no? Yes. So please keep this in mind. Yes. Okay, moving on. Yes, again a revision. Hysteroscopy is done for all of the following conditions except, anybody? Yes, very good. So again, if you know the logic, that's a hysteroscope is putting in a telescope through the cervix into, through the vagina into the cervix to see the uterus cavity, we know the answer. Okay, yes, yes. Okay, that sir, whenever a patient, whenever a patient has got menorrhagia. What could be the causes of menorrhagia? So there could be a polyp, there could be a submucosal fibroid, or there could be infertility because of what is this? What am I drawing over here? Intrauterine adhesion. What is this called as? Anybody? Intrauterine adhesions. No, beta, Pratyusha, adenomyosis will mainly go in for ultrasonography. Yes, very good. Okay, so anybody, what is this condition called as? Intrauterine adhesion. इसको क्या बोलेंगे? Yes, intrauterine adhesion. Intrauterine adhesion, specifically called as Asherman's syndrome. And as I already told you, very good, Mirthula, Kavi, and also septate. So all these conditions, as I told you, it could be a polyp or a submucosal fibroid or intrauterine adhesion. They will also cause heavy menstrual period. Yes, they will also cause our infertility. So sir, in any patient of Asherman syndrome, in any patient of menorrhagia and infertility, all these cases we are going to be helpful for hysteroscopy. Adenomyosis is what? Adenomyosis is glands. Adenomyosis is the option or endometriosis. So they are glands within the myometrium. So ultrasonography, sometimes very rarely MRI, adenomyosis is the glands, menstrual glands, endometrial glands within the myometrium. Okay, within the myometrium, which I will not see on hysteroscopy. Is this understood to all of you? Yes, so short 5-star MCQ लिख के ले लो. This is going to come आने ही वाला है. And as I said, hysteroscopy is not only for diagnosis of all this condition. Simultaneous treatment, simultaneous surgery can be done for all these conditions. We can go through the hysteroscopy route and cut the polyp, cut the fibroid, cut the septum, break the adhesions, and do hysteroscopic adhesiolysis. Okay, you can see over here like this. We can keep on cutting the adhesions. समझ में आ गया? So please don't make a mistake between your hysteroscopy and laparoscopy. Short MCQs are going to come. Okay, and all those who have joined in now, after the stream is over, do go back and see the entire video from the beginning. You're really going to benefit with all the MCQs. Again, a short question. I'll give you 2 variations in this MCQ. Anybody, according now to the MTP Act, MTP is allowed till what weeks of gestation? No, Neha Tanveer. Okay, so please understand that MTP was allowed till 20 weeks of gestation, and specifically now this has increased to 24 weeks of gestation, and therefore the answer is 24 weeks. Because why? Sir, why was this done? Anybody? And which indication I can do for 24 weeks? Yes, very good. I'm coming to that, Mithula. Okay, sir, fetal anomaly. Sometimes what used to happen, sir, if the baby has some anomaly, chromosomal anomaly, structural anomaly, so some genetic problem in the baby or some fetal anomaly were detected at 21, 22 weeks, then I can now terminate up to 24 weeks. And special circumstances like rape victim, sexual assault cases, all that cases also now we can terminate up to 24 weeks. Keep in mind. And there are some special circumstances which is now told, that example like a divorce, a couple undergoes divorce during pregnancy. So some special conditions like rape, sexual assault victim, genetic anomalies, fetal anomalies were detected later 20 weeks. But very, very important, and again short, remember my dear students, कि failure of contraception, if the condom has failed, condom फट गया है, you can't be sitting at home till 24 weeks. So failure of contraception, whatever method used for failure of contraception, still it is only up to 20 weeks. Clap if you have learned something new. Clap if you are liking the MCQ. So please read the question correctly and how the wording can happen. Suppose if they tell you that for failure of contraception, the MTP is allowed till how many weeks, then 20 is still the answer. Okay, 20 to 24 is for this conditions which I have told you: fetal anomaly, rape, sexual assault, all that. Yeah, beta beyond 24 weeks, but it's not no limit nahi hai ke gross anomalies, but after 24 weeks you have to go to the court and the medical board will be constituted, and then the court will give permission then also. Okay, and mother life is at risk, then of course anytime. Is it clear to all of you? So please understand this, that failure of contraception abhi bhi 20 weeks tak hi hai. Yes, and very good black cam. I was going to discuss this point right away, that please keep in mind that in the old law up to 12 weeks only one doctor tha, and after 12 weeks, okay, after 12 weeks two doctors had to give the opinion. Which has now that, sir, in the new law up to 20 weeks only one doctor opinion can be given. One doctor opinion gives. Consent is of the mother, okay, consent is of the pregnant lady, and after 20 weeks two doctors have to give the opinion or certification that yes, MTP is required to be done. Okay, so please keep this in mind. Very good. Again, short MCQ. Patient wants MTP at 45 days. Anybody? ये जो tablets है, medical method is up to what weeks of gestation? Anybody? Medical method can be done till how many weeks? Yes, very good. KK, husband consent not required. Very good. Yes, very no beta. Akanksha and Chitramadi Sai, that 7 weeks was the old. Now even up to 9 weeks, okay, up to 9 weeks or 63 days we can go for the medical method. Is this understood to all of you? Yes, okay, up to 9 weeks we can go till the medical method. Now what is the drug? And again short this picture could also be asked to you. Kya hai picture? Like this. Okay, there is going to be one single tablet and 4 tablets like this, and total confusion which are the tablets. Chalo, tell me the answer. Pehle answer bol denge. A B C D. Okay, so please keep in mind all of you that 2 drugs are given, and how will you remember is, clap if you feel happy, MIFI is given first. MIFI, why I will remember, how I will remember? So because यहाँ पे आता है F, so F first, and after 48 hours we will give Misoprostol, again S stands for second. Okay, second tablet because S, clap, ठोको ताली. So F is given, जिसमें मीफी है is given first, F वाला is given first, and mifepristone is a single tablet of 200 milligram. This is 200 milligram. So remember student, यहाँ पे मीजो आउट, ये मीजो फर्स्ट है तो ये आउट. मीथोट्रेक्सेट आई डोंट गिव. अगेन ऑप्शन डी ऑल्सो आउट. Misoprostol out because miso first hai and then mifi after 48 hours. Wrong, wrong, wrong. Now yes, between 1 and 2, between A and C क्या choose करेंगे? Why option A is not the answer? Yeah, F means first beta. Yes, why first is not the answer? Why A is not the answer? Because it is not 200 microgram and not 800 milligram. Okay, is this understood? The mifepristone is 200 milligram and meso, you can see each tablet is 200 microgram and totally there are 4 tablets, so it comes 800 microgram. Is this understood to all of you? Yes. So the answer is option number C. Mifepristone 200 milligrams and misoprostol 800 microgram after 48 hours is the answer. Please don't make a mistake in this. Surely this is going to come. Is this understood to all of you? Okay. Yes. So don't make a mistake. Okay, and we repeat sonography generally after 15 days to make sure that everything is clear. There should not be any retained products of conception. Okay, 48 hours gap, that's why this is day 1 and then this is day 3. Okay, yes, moving on. MCQ, what is this image? Chalo, what is this instrument and this device? Yes, black chem sublingual is better. Oral can also be given. This na meso jo hai, meso is a multifaceted. Mifi is always Mifi is always oral. Meso can be given per vaginal also, sublingual also, oral also. But oral lot of nausea, vomiting. So PV methotrexate beta, we don't use it, okay, in medical abortion. Technically yes, KK methotrexate can cause MTP abortion, but we don't give because it's a, of course, a cytotoxic drug, so we reserve it only for ectopic and all that. Yes. So what is this instrument, anybody, and what is the role of this instrument? So this is what? Very good. This is the uterine sound. To sound the uterus, to basically you put this inside the uterus so that we will know what is the uterocervical length. Tell me the answer. Answer kya hai? Read the question. Least likely. This device is least likely to be used for which condition? Yes. DNC, suction evacuation, IUCD insertion, removal of IUCD. Clean bold. Okay. Okay. So basically sound acts like a first dilator and sound is going to be helpful to me for measuring the uterocervical length, basically, so that for any instrument which I put inside the uterus, what will happen if I put excessively, बहुत ज़्यादा अंदर घुसेड़ दिया तो क्या हो जाएगा? Yes, uterine perforation. So that is why remember कि any condition where intrauterine manipulation is going to be done, where sir I will dilate the cervix and then the curate I will not put too much inside. Whatever is the UCL, you will be less and then only scrape. Similarly, suction evacuation also we sound the uterus, and IUCD insertion also we have to sound the uterus and then only put in the IUCD, because otherwise all this thing, there is a risk of perforation of the uterus if you go beyond the uterocervical length. Please understand, removing of the IUCD, in removing there is no role. There is least likely to be used or not used. Least likely to be used for, yes, very good, Chitram Reddy Sai. Removing of the IUCD, all of you know how will I remove the IUCD? Yes, okay, sir, IUCD, so directly it is here like this. It is here like this, and there are the threads, isn't it, my dear student? So the threads are directly grasped with the artery forceps, and just with the artery or any of the thing, I will remove the IUCD. Okay, so just a artery forceps or any grasper or anything, we will remove the artery, we will remove the IUCD. So for IUCD removal, we no need. Okay, sound is not required, sound is not needed. Is this understood to all of you? Okay, for IUCD removal, the sound is not needed. We just, there is no role of the uterine sound. Okay, thumbs up, clap if you have learned something new. Okay, yes, very okay. So basically जहाँ पे भी even hysteroscopy, DNC, suction evacuation, IUCD insertion, ये सब में हम sound use करेंगे. Okay, moving on. Yes, very simple, short again आने ही वाला है. Okay, आने ही वाला है. Do not forget to hit the like button, all of you, and quickly share the link with all your, yes, only artery forceps. Okay, quickly tell all your friends about this session which is going on, and please share the link in your group so that more and more students can join us live for the session. Okay, is this understood to all of you? Yes. Moving on. Yes. What is this? Yes. So please understand specifically which ovulation induction agent. Sir, when the HMG, human menopausal, yes, very simple, will not discuss it much, most of you already aware of it. HMG or recombinant FSH is used, and along with it HCG. HCG is the big culprit. What are we seeing? Yes, sir, we are seeing a ovary which has got big follicles all in the center, and along with it, yes, remember HCG is the main culprit. When HCG is given, there is development of OHSS, which is the answer over here. But they should also actually give the picture of ascites, because please understand, student, PG level, ascites has to be there, or free fluid, because only this could also be a stimulated ovary. Okay, a stimulated ovary will look like this, basically big follicles. So ascites or free fluid in the pouch of Douglas should also be seen generally, which is a feature of OHSS. Anybody, why is it not PCOS? Why is it not PCOS? Yes. Okay, so please understand this, that very good, Pratyusha, KK, Zahir, all of you, superb point, that sir, in PCOS what we are going to get is multiple small follicles, and that also in the periphery. Yes, multiple small follicles in the periphery, which is going to be PCOS. Don't make a mistake, and compared to this with our OHSS, we are going to get big and many follicles which are also coming in the center, and along with that free fluid. Okay, yes, and clap if you have learned something new. What is, if they ask you what is the biochemical mediator for development of OHSS? Virgin MCQ 2027 next level INI-CET MCQ. Okay, ये OHSS, interleukin, cytokines, all that, but VEGF, vascular endothelial growth factor, is a chemical mediator responsible for having for a development of this condition? Yes. Okay, excellent. So this is a very difficult MCQ likely to come in the future exams, and you will remember this. Okay, so don't get confused. Moving on to the next MCQ. Yes. Okay, anybody, again a clinical case based scenario. Okay, and do not forget to download the OGGuru app, and all of you can go for rapid revision MCQ. Also get in touch with me for your timetable and guidance. How to prepare, I will guide you. In just one day time you can revise all the MCQs. Yes, chalo. Now tell me, first of all, patient had 11 weeks pregnancy, had a incomplete abortion, okay, underwent a check curettage. 4 months after that, she has still not got her periods. She has come to us with secondary amenorrhea, but FSH is 5. Now please tell me, this FSH 5, is it normal, less, high, more? And with this one MCQ, clap if you feel happy, I will teach you 3 more MCQs. Yes, very good. Sir, FSH 5 is normal. FSH 5 is normal. Why? Remember, anything more than, so 4, 5, 7, 8, even up to 10, na, all will be considered normal. Okay. Yes, very good. And remember this, that out of the 3 A, B, C, D, obviously D to nahi hai, it can't be all. Okay, when master servant relationship, if the ovaries will fail, if the ovary will fail, FSH will become very, very high, isn't it? Okay, and when the master himself is sleeping, pituitary failure hai, so FSH is going to be very, very low. And in intrauterine synechiae, which is the uterus, FSH will be normal. FSH will be normal, and 5 over here is normal. Now suppose, tell me, all of you, suppose if I make this FSH of 5, if I make this FSH of 5 into 50, what is the answer? If I make this FSH of 5 into 50, chalo, what is the answer? Yes, very good, all of you. Sir, then the answer will become ovarian failure. And if I make the FSH of 5, if I make it FSH 0.5, if I make the FSH 0.5, 0.1, then what is the answer? Yes, sir, then the answer is pituitary failure. Is this understood to all of you? So please don't make a mistake. Ek word, that is the importance, that when you listen to the lectures, even one word, ek MCQ, even one letter change, the answer can change. Okay, so please don't make a mistake in this. I'll keep the MCQ as it is. So since the FSH is 5, which is normal, please keep in mind it is your intrauterine synechiae. Here FSH, I told you, if they give you 20, 30, 40, 50, all that is high FSH. And if they give you FSH 0.5, 0.1, all that is low. Okay, so please don't make a mistake in this type of MCQ. Yes, now one of the students asked me, okay, yes, anybody, chalo, what is this, on Insta? One of the student had put a request of this MCQ. Okay, sir, please teach about the fetal ka diameter and the malpresentation. Okay, what is the diagnosis? Yes, okay, Dr. Jaya Thakur. Dr. Jaya Thakur, beta, are you there? Dr. Jaya Thakur had also put in this request on the Insta, and along with that, even the NEET 24, med underscore NEET underscore 24, that put in the question that, sir, I would like you to discuss about the mal presentations and fetal, which diameter is there in which presentation, let me know. So anybody is there? Are you there? Dr. Jaya Thakur, are you there? And Dr. Medney 24, okay, and Dr. Saikat Basu, your topic of prolapse also, you had said about some prolapse management. I'm going to take in some time now, okay, yes. So what is this? Chalo. What is the diagnosis? Patient 39 weeks, labor 10 centimeter to fully dilated, and on PV examination, supraorbital ridges are felt and anterior fontanelle is palpable on PV examination. What is our diagnosis? पहले diagnosis तो बताओ सब बच्चे लोग, आंसर सब बोल रहे हैं. And fetal heart rate, okay, what is the most appropriate plan of management in this patient? Okay, so sir, again remember, phase is from year to year. In phase, I will feel the baby's malar. Okay, so when I do a PV examination, this is the pelvis, this is the baby, and if I feel the baby ka nose, mouth, malar, my finger goes in the baby's mouth, that is the face presentation. Okay, and face mein hoga mento anterior, mento posterior, depending on where the mentum is. Okay, if the mentum is towards the pubic symphysis, I call it mento anterior. If the mentum is towards the sacrum or sacral promontory, you call it mento posterior. But in the very good sweetie, excellent, okay sir, when there you feel the supraorbital ridges and the anterior fontanelle, this is a brow presentation. And sir, in brow presentation, there is no mechanism of labor because the engaging diameter mento-vertical 14 centimeter. Thoko tali, and therefore I will go for immediate LSCS because she is already 10 centimeters since 1 hour. Okay, she's already fully dilated. Brow in early labor can change. Brow can become flexed to vertex, extended to face, but I will persistent brow. Remember student, if it is a persistent brow, okay, so this year I have put the this is mento posterior, okay, because just today this is mento posterior face because mentum is towards the mento posterior face. Also persistent brow, there is no mechanism of labor, and I will go and do LSCS only. Okay, you can go and check out the malpresentation video. So I will not encourage her to push, sorry, because it is not going to deliver. And you don't do rotation forceps, all that is all kachra dustbin. Rotation forceps, all that is not done. Okay, rotation forceps is not done, and you don't convert to mento posterior and allow vaginal lever, sorry. And similarly, you are not doing internal podalic version. Internal podalic version is not done almost nowadays today. So LSCS. So basically remember the diagnosis, Virgin MCQ shortly coming in the future. Very good. Mento vertical diameter 14 centimeter, persistent brow, LSCS. Thoko tali, clap if you have learned something new. Okay. Is this understood to all of you? Yes. Moving on to the next MCQ. Yes, somebody had requested for prolapse management. You asked, we deliver Saikat. Okay, I hope if you are there in the video, Dr. Saikat Basu 02, you had put, okay, sir, please teach me prolapse management also. Okay, so Fothergill's repair is associated with all of the following complications except is the question. So anybody, can you tell me what is the main step of Fothergill operation? Yes. So remember, the main step of Fothergill surgery is cervical amputation. Cervical amputation. Okay, cervical amputation is the main step of Fothergill. Very good. And therefore, anybody, what can it lead to? Yes, sir. Whenever I chop off the cervix, whenever we chop off the cervix, cervical amputation, what can it cause? Sir, either because of this cervical amputation, cervix can become too tight. Yes, cervix can become too tight, and there could be cervical stenosis, which could lead to cervical dystocia and even infertility. Cervical dystocia means during labor the cervix is not dilating, but more danger is when there is cervical incompetence. Okay, cervical incompetence. And very good, Panna Kumar and Parth and Panna, very good. Okay, sir, cervical incompetence will cause always repeated second trimester abortion. Is this understood to all of you? Repeated second trimester painless and not the first trimester, which is the answer over here, because first trimester abortion, the causes are chromosomal and genetic. So cervical dystocia can happen, and yes, similarly the cervical incompetence can also lead to preterm labor, but mainly it causes repeated second trimester abortion. Is this understood to all of you? So first trimester abortion नहीं होता है, first trimester causes are chromosomal and genetic, keep that in mind. And therefore, can anybody tell me what is the surgery nowadays preferred for young patient? Anybody? Young patient के लिए what is the best surgery if they ask you? Fothergill is outdated. Fothergill is hardly ever done because of so many complications. And therefore, remember, how will you remember? 15 years back, Akshay Kumar movie had come, Sing is King. Okay, Sing is King, and all of you will remember Thoko Tali, Sling is King. Okay, Sling is King matlab ke sling surgery is the best surgery for the young patient of prolapse. And therefore, whenever you get a MCQ, okay, sir, there is a patient who is young patient of prolapse, the best is sling surgery. Purandare sling, Khanna sling, Virkut sling, all that slings are there, Shirodkar sling. So remember, Fothergill is no longer done for so many complication. Sling is king, sling is best. Hokotali, clap if you have learned something new. Okay. Yes. Okay. Yes. So all of you, please keep this in mind and do not make a mistake. Yes, sing surgery for young. Okay. Yes. Moving on to the next very important MCQ, which is your severe abdominal pain and torsion is suspected. Next best investigation. What will you do? Anybody? Yes. Please understand, the important point is, sir, whenever there is torsion, we want to see whether the vascular blood supply, because in torsion, in twist, the blood supply will get compromised. And whenever I want to check the blood supply for anything, because when the pedicle will twist, yes, very good, a dermolysis is most likely to undergo torsion. So what happens is that, of course, severe abdominal pain, vomiting bhi hota hai, patient will also have vomiting, and therefore please understand, CT scan and MRI will only tell me the size of the cyst. but specifically color Doppler is to be done. Keep this in mind. Again, a PYQ surely asking. Okay, sir, color Doppler will tell me about the blood vessel, whether the blood supply is compromised or not. It is a vascular pedicle, because when the vascular pedicle will twist, the blood supply will get compromised, and there could be a necrosis of that part. Okay, necrosis of that part. Okay. Now, yes, okay, so before we quickly go, all of you definitely please start following me on Insta, because every day we are posting lots of MCQs. Every day MCQs are being posted, lots of reels are posted, and do hit the like button and share this with all your friends. And also, after the session is over, on the Telegram channel, I'm going to put this entire annotated PDF. Okay, the annotated PDF will be available on the Telegram of this whole session. Okay. And yes, I've already told you, do download the OGGuru app, and all of you can go in for the rapid revision MCQ discussion, which is available for the upcoming NEET PG examination, and those who are giving examinations in the next year and afterwards, also 6 months, 12 months. So depending on the requirement, even 6 months, 12 months packages of entire topic, entire OBGY in detail is available. So all of you can go in for that also if your exam is next year. Yes, one of the most important MCQ, again, that doctor had requested me that, sir, please tell me about the management of eclampsia, pre-eclampsia. Okay. Yes. Okay. Anybody? What is the diagnosis and what is the yeah, beta Parth, you can come on the OGGuru app, and you will love the lectures again, and entire much more detailed lectures are also available for your entire preparation is available. Okay. Yes. Now please understand, here the patient is having blood pressure of 180, 110, albumin +4, no convulsion. What is the diagnosis? Anybody, what's the diagnosis? And headache, oliguria, blurring of vision. So anybody, क्या है diagnosis? Yes, 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 yes. But the labetalol देंगे BP के लिए, very good. But I want a diagnosis. Yes. So what is the diagnosis of this? Is this patient eclampsia? No, this patient is not eclampsia, because this is impending eclampsia. Anybody? Why am I telling it is impending eclampsia? Yes. Very good. Yeah, Pratyusha. Okay. Why am I telling impending eclampsia? Because headache, oliguria, blurring of vision, and two more if they give you also epigastric pain and nausea, vomiting. Please by heart this 5. These 5 are called as the premonitory symptoms. They are the dangerous symptoms. What do you mean by premonitory symptoms? Headache, oliguria, epigastric pain, nausea, vomiting, blurring of vision. They are telling you that yes, the patient is not only severe preeclampsia because BP 180, 110. This is a patient of impending eclampsia. Okay. Now all of you know, clap if you feel happy. हिंदी पिक्चर में देखा होगा कि डॉक्टर पूछता है माँ और बच्चे में से किसको बचाना है. Anybody, to whom to save? Do I save the mother? Do I save the baby? Do I save both? Do I save the tiger? Doctor bolega save the tiger, save the doctor first. So please understand this, that whenever there is impending eclampsia, so the patient is only 33 weeks. Please understand that when the patient in impending eclampsia, let the patient be 30 weeks, let the patient be 32 weeks, 34 weeks, 36 weeks, or even 28 weeks, or even 24 weeks, the answer will not change. Can anybody tell me why? Never wait and watch. Because this condition is so dangerous that if I wait, mother will die. तो माँ और बच्चे में से माँ को बचाना है. मदर इज मोर इम्पॉर्टेंट. मदर है तो पीछे पूरा क्रिकेट टीम आ सकता है. Okay, the whole mother can have as many babies as she wants afterwards. So in a patient of impending eclampsia, please understand this, that I will have to go and do the delivery of the patient, because all of you, yes sweetie, you cannot try to save both. Baby bach gaya, very good. Okay, why I have to do the delivery? Because delivery is the definitive treatment. So please understand this. Again, draw 5 stars around this word. But before I proceed further, very good, we will give magnesium sulfate. Now, can anybody tell me why I will give magnesium sulfate? Why I will give magnesium sulfate? Why I will give magnesium sulfate? So wait and watch. Never. Okay, never direct LSCS. And again, magnesium sulfate, yes, laboratories, but never deliver at 37 weeks, because you are already 33 weeks. That means it's telling you to wait. So this is also gone. Very good. The answer is magnesium sulfate to prevent convulsion. This is prophylactic magnesium sulfate. Labetalol to control the blood pressure, and induction of labor. This is the answer. Is this understood to all of you? ये MCQ surely आने वाला है. You will remember me on the day of the exam. Yes, this is called as prophylactic magnesium sulfate, and then you have to go and do the delivery. Again, remember dear students, max sulf के बाद again you cannot wait and watch. You can never say कि चलो max sulf दे दिया, now I will wait. Sorry. Okay, and by this delivery we will go for induction of labor first. If required LSCS, yes. Okay, if required LSCS, okay. If SOS, okay, SOS LSCS, but we can try induction of labor first, or sometimes direct LSCS. That will depend. Okay, that will depend on what is to be done. Very good. Here magnesium sulfate is given prophylactically. And similarly, if in the question paper they put the word it is eclampsia, also not a problem. Same management will be there. Magnesium sulfate and delivery. Most important words coming in the bracket, irrespective of weeks of gestation. Is this understood to all of you? So please don't make a mistake. Whether it is eclampsia, impending eclampsia, management is cut, copy, paste, same. Delivery is the definitive treatment. Immediately delivery should be done. So I hope all of you get this correct. We will not wait. Okay, mother is more important. And anybody, when I give magnesium sulfate, next MCQ. What is the therapeutic range of magnesium sulfate to be achieved? Yes, very good. Okay, crystal clear in the chat box. OG in the chat box. Okay, yes, sir, simple. 4 to 7 milli equivalents per liter is the therapeutic range of magnesium sulfate to be achieved. Very simple. Do not make a mistake. And if the levels become high, there could be respiratory paralysis, cardiac arrest. What is the antidote? What is the antidote? For magnesium sulfate toxicity, yes, calcium gluconate is the drug of choice for magnesium sulfate toxicity. Yes, excellent. Yes, knee jerks will become depressed, and urine output should be at least maintained to 25 to 30 cc per hour. Okay. Anybody? Yes. Now again, I want the diagnosis first. What is the diagnosis? Okay. Yes, again a very important clinical case. We have a patient, primi gravida, 5 hours, strong contractions are there, but uterine size 32 to 34 weeks. Anybody? Lower pole empty. ये क्या है? Fetal head on right side, fetal heart sounds absent, IUFD, and PV पे shoulder felt. Anybody? What is the diagnosis? Again a short MCQ, again very important. Okay, yes, so no Panna Kumari will. Okay, so what is the diagnosis, my dear students? Remember, okay, this is transverse lie. In transverse lie, please understand this, that the lower pole will be empty. Okay, that is the important point. Lower pole will be empty, and that is the reason in transverse lie, when I do a PV examination, we will feel the baby's shoulder. So shoulder felt is the same as transverse lie, or shoulder is the presenting part, is the same as transverse lie. And in the question paper, if they give you lower pole empty, that is the clincher. And that is why also remember, okay, the uterine height, okay, because the uterus will be like this only. Okay, generally itna space nahi hota hai, so that is the reason why the fundal height is also lesser. Okay, very important clinical question, don't make a mistake in this. That is why generally the uterus will be transversely stretched like this, and you will get a dip in the fundal height. Yes, the fundal height will not be as like a normal pregnancy. So that is also given over here. Okay, sir, she is 37 weeks, but the uterine size is only 32 to 34 weeks. That is also a very important observation. Is this understood to all of you? Now what will I do? Yes, please understand this. Transverse lie, again remember, there is no mechanism of labor in transverse lie. What will happen? What will happen if I wait, rupture uterus? Uterus will, mother will die, baby will die, but the baby will still not come out. Okay, because if you wait and watch, there is rupture uterus. And yes, coming to Myrthula, what is the indication of decapitation? Nothing. Okay, please understand, all this is kachra dustbin. कचरा डस्टबिन, क्लैप इफ यू फील हैप्पी. कचरा डस्टबिन का मतलब है कि सर कचरे के डब्बे में डाल दो. Okay, is this understood, Mithula? Never. So all this craniotomy decapitation was done 100 years back. Here you go inside and cut the baby, टुकड़ा टुकड़ा करके baby को निकालने का. All this is no longer done. Is this understood to all of you? So evisceration, craniotomy is never to be done in modern day obstetrics. If this understood to all of you, you will never mark this in the answer, and therefore LSCS is the only option for transverse lie in labor. Because see, there is already 5 hours, already strong contraction, already 4 centimeter dilated. I will not wait further. There is no mechanism of labor. And see, they have given FHS absent to confuse you. कि चलो baby is dead, mark something else. No, whether FHS absent or whether fetal heart rate normal, whatever may be the answer, whatever may be the MCQ, your answer will not change. Your answer will remain always LSCS. Is this understood to all of you? So whether the fetal heart sound is absent or fetal heart rate is given to you as normal, also answer LSCS. Again, internal podalic version is not to be done, because when you rotate the baby inside, lot of rupture uterus and all that complications are happening. Okay, and you will not wait and watch, because there is rupture uterus ka complication will happen, because there is no mechanism of labor in transverse lie. That is the take home message. So dear students, transverse lie in labor, LSCS directly mark karna hai in labor. If the patient is not in labor, then we may do a external version. Okay, then external version can be done. Is this understood to all of you? Yes. Moving on to the diagnosis. Again, a clinical case scenario. "36 weeks pregnant lady has come to the OPD with a painless bleeding 36 weeks. So we are patient is in the third trimester. Okay, third trimester bleeding, and the uterus is relaxed and BP is normal and the head is floating. Chalo, tell me the diagnosis. A, B, C. Simple C नहीं है, eclampsia नहीं है, because eclampsia में we know there is convulsion and high blood pressure, वो नहीं है. So that is just to confuse you. Okay, so A और B में से choose करना है. Yes. And again, remember my dear student, again a short MCQ, that when we have bleeding in the third trimester, when we have bleeding in the third trimester, what are the two things to be kept in mind? Sir, either it is placenta previa or it is going to be abruption. And my dear student, keep in mind the main difference kya hai? Placenta previa is a painless bleeding, abruption is always painful bleeding. And placenta previa, pre-eclampsia is not at all related, and in abruption most of the time the patient will have pre-eclampsia history or hypertension and the blood pressure is going to be increased. Okay, yes, and therefore this is the thing, that sir, there is painless bleeding, BP normal and head is floating. This is our placenta previa rather than abruption. Anybody, why head is floating? Floating head मतलब क्या? Head floating मतलब क्या? कहाँ पे float हो रहा है head? Yes, head floating का another word, head is unengaged. Why the head is unengaged? Because sir, the placenta previa will prevent the head from coming down. This is the placenta. So the baby will always be, head will be up, and therefore the head is floating. Is this understood to all of you? Now can anybody tell me what is the management? Next MCQ. Again the diagnosis first. Again the diagnosis first. Okay, so remember this, that patient is admitted in view of painless bleeding and uterus is relaxed. So the diagnosis is placenta previa is our diagnosis. And what will I do? What will I do? Placenta previa, I can wait and watch. Abruption, never wait and watch. Now anybody, look at the mother. Is the mother stable? Yes, sir. 11-gram hemoglobin, BP normal. Look at the fetal heart sounds normal. Please understand this. Yes, yes, yes. All of you are saying C-section, but very important point. Okay, it is yes, Soumyadev Mirthula. Okay, we are only 33 weeks and therefore I can wait and watch, and that is the answer over here. Why I will wait and watch? For the baby lung maturity, because the mother is stable. And also please see the fetal heart rate. Fetal heart rate is also normal, and therefore yes, wait and watch is the answer. और anybody, इसको क्या बोलते हैं? क्या बोलते हैं जिसको हम wait and watch करेंगे? Regimen of expected management. Yes. No, beta, never till 39 weeks. You wait till only 37 weeks. And that is McAfee and Johnson regime. Very good. Okay. McAfee and Johnson regime. When we wait and watch in a patient of placenta previa. Brand Andrews maneuver is control cord traction to deliver the placenta. Control cord traction to deliver the placenta. That is the answer. Is this okay? Okay. And all of you do hit the like button and share the link and share this video with at least 2 of your friends immediately right away is the thing. Okay, so McAfee and Johnson regime is the answer over here. And here remember that suppose the first word, all of you pay attention. Now if I go to the MCQ over here, and if this 33 weeks I make it as 37, 38 weeks, then the answer is cesarean section. Is this understood to all of you? Because sir, once we have reached 37 weeks, then there's no point waiting further. Okay. बेटा वीरेंद्र प्रताप इन व्यू ऑफ, ओके या IVO मतलब इन व्यू ऑफ, obviously in the exam they will give you the full form also, okay, in view of, okay, admitted in view of, okay. Beta Gunner's AD, Creed's method is outdated method. Creed's method is outdated method for placental delivery, which we no longer use. Usme we used to squeeze the fundus also. Okay, so Creed's method, again outdated kachra dustbin, there was risk of uterine inversion. So we do not follow Creed's method. Okay, is understood to all of you? Yes. Moving on, Creed's method beta bata diya Gunners aapko. Creed's method is a method for outdated method for placental delivery का method था. Yes. Moving on to the again a clinical case based scenario. All of you pregnant patient 32 weeks and simple diagnosis के 29 weeks is the estimated fetal age. 29 weeks is the estimated fetal age. Okay. What is the diagnosis? Yes. So ये क्या है? Yes sir, this is a simple thing. IUGR, intrauterine growth restriction, is simple. Don't get hassled by the big number, big MCQ. Okay sir, patient is 32 weeks but growth is up to 29 weeks. So hypertension, yes, hypertension, preeclampsia, oligohydramnios, placental infarcts, any infection, all that will cause, not poly beta, poly में उल्टा होगा, okay, poly में उल्टा होगा. So this is all except पूछा है gestational diabetes, because GDM में क्या होता है? Yes, GDM में तो बेबी बड़ा होता है. Okay, yes, oligo could also be there and oligohydramnios or IUGR. Okay, see, oligo में only the flu. Here clearly the fetal age is 29 on sonography. Okay, so it is only IUGR, not oligo. Oligo is associated with IUGR. Here clearly baby is only small and gestational diabetes में तो क्या होता है? Big baby होता है, macrosomy, छोटा हाथी, big baby. Okay, is it clear to all of you? Clap. Okay, large baby, simple MCQ. Okay, moving on to the next MCQ. All of the following, very again short, emergency contraception except. Yes, beta. Crivery, yes. Placenta previa bleeding patient can be vital if it's only small bleeding. Okay, crivery, it is. All placenta previa will not be in shock. Okay, beta, crivery. So placenta previa patient can go in shock, but in placenta previa all patients are not in shock, and therefore we can wait and watch. We will wait and watch when the mother is stable, obviously. Okay, when the mother is stable, we will wait and watch. Okay. Is it clear, beta? I hope you have got the answer, Crivery. Yes. Okay. So now moving on. All are emergency. Yes. So all of you remember emergency contraception. I-pill को क्या बोलते हैं? एक ही गोली, brand name I-pill. I-pill is the brand name. Even if we don't remember that, it is okay. But LNG 1.5 milligram is the emergency contraception most preferred. Okay, preferred. And IUCD is up to 5 days. Very good. Misoprostol, my dear student, is not for emergency contraception. Misoprostol we use for MTP and in PPH, yes, up to 72 hours. So misoprostol is never for emergency contraception. And anybody, surely this MCQ is coming, something new. What is this? Ulipristal. Ulipristal is a new drug. Ulipristal is a selective progesterone receptor modulator. Clap if you have learned something new. And it is also, we can now oral tablet which we can give up to 5 days following sexual exposure. Is this understood to all of you? Yes, it is now available in India. And anybody with the dose, एक बार dose बता देंगे, next year 2026-2027 Virgin MCQ surely coming. Ulipristal का dose for emergency contraception 30 milligram single dose. 30 milligram, very good. Wanna be neurosurgeon, excellent. Okay, 30 milligram can be given single dose stat. Yes, all of you, Chitra Reddy Sai, all of you correct. Moving on, again now like a revision. Chalo, now like a revision, and again match the column style of MCQ. McAfee and Johnson we already discussed is the wait and watch when I do with placenta previa. So 4 is B. 4 is B. Okay. And you know the answer. Okay. Burns Marshall is for what? All of you. You hold the baby by the lower limb and up, 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 up. Burns Marshall is for the after coming head of the breech. Okay. After coming head of the breech. And remember, Wood's maneuver is one of the maneuver for shoulder dystocia. So 2 is going with F. 2 is F. ये दोनों out. Very good, all of you. And coolier uterus is, uterus becomes bluish purplish mulberry color ka, and that is 3A. So very good. Answer is option number 4, all of you. So again, I like match the column so much with one type of MCQ you get. Coolier uterus is when the blood goes retrograde in between, and specifically with concealed abruption. In concealed abruption, we get coolier uterus. Okay. Yes, perfectly correct, all of you. Do not make a mistake in this. Yes. Again, now the diagnosis. Again, now the diagnosis. Yes, Mac Roberts is the preferred. Suprapubic pressure and Mac Roberts given first. Yes, so what is the diagnosis over here? Simple. Sir, patient after delivery starts bleeding. So, and cervix vagina healthy, but the uterus is flabby. So, ये क्या है? Sir, this is not only PPH. It is, yes, it is a tonic PPH. Okay. Atonic PPH is the diagnosis, and all except misoprostol. Yes, I gave oxytocin. And anybody ये क्यों question लाया है? Because surely ये साल, what is this carbetocin? Carbetocin, 5-star mark करो. Mifepristone is the answer. Mifepristone is only for, you know, MTP. Okay, so it is for MTP. Yes, yes. Oxytocin is the first drug of choice. And anybody, what is this carbetocin? Yes, very good, Crevery. All of you correct. Tranexamic acid should also be given. Very good. Tranexamic acid should be given first only. Yes. What is this carbetocin? Carbetocin kya hai? Yes, D is the answer. Carbetocin, my dear student, is a oxytocin derivative, oxytocin analog. Sweetie, but kya specifically a synthetic? It is stable at room temperature. That is the main thing. In India, the storage ka issue hai, to stable at room temperature is very, very important. It does not require refrigerator. Clap if you have learned something new. It is a heat stable. Okay, beta, carbopros is different. Okay, beta, gunners, carbopros different. Carbopros PGF2 alpha. Okay. Is it clear? So remember, carbetocin is stable at room temperature. It is a oxytocin derivative. It is a oxytocin derivative, but the important point, now available in India. You will remember me on the day of the exam is my guarantee. OG in the chat box. Okay. Yes. Now what is the diagnosis? Okay. So again, some student had told me. Okay. So quickly share the video, and I hope, yes, Dr. Shweta. Okay, Dr. Shweta had put on the Instagram that this, sir, please discuss about the management. What is the diagnosis? Simple. तो क्या है? 2 months amenorrhea, early pregnancy. Pregnancy है because the beta HCG is positive and uterus is empty. Simple, simple. Okay. Okay, sir, uterus is empty, but the patient is pregnant, and there is adnexial mass of 2.5 by 3 centimeter. So this is a ectopic pregnancy, but more better answer, because sir, pulse 80, BP 120, 80, hemoglobin 11. Very good. This is unruptured ectopic pregnancy, and in unruptured ectopic pregnancy, when the criteria are satisfied, methotrexate is the answer. You will never repeat USG after 2 weeks. A patient bomb blast ho jayega, ectopic will rupture, so you don't wait for 2 weeks. Again, you never, if you wait and watch, you'll have to go to jail. Okay, unruptured ectopic, you wait and watch, you'll have to go to jail. And surgery, my dear student, is generally reserved when the patient has ruptured ectopic. You then go for a surgery. And very important, very important for methotrexate, what are the criteria? Okay, sir, when the patient is stable, when the patient is stable, or it is unruptured. And what is the sac size? The gestational sac size should be how much? Should be less than 4 centimeter, which is over here. Please see, the sac is only 2.5 into 3 centimeter. So when the sac is only 2.5 to 3 centimeter, as is the case over here, I can, yes, single and follow up with single dose methotrexate intramuscular, and follow up with HCG monitoring. Now please pay attention over here. Yes, and very good, Akanksha. Also, the initial beta HCG should be less than 5000 micro international units per ml. Please by heart this. And also preferably remember at your level, my dear students, fetal cardiac activity should be absent. Now on day 4, प्लीज अंडरस्टैंड, यू रिपीट द HCG. ध्यान से सुनेंगे. इफ ऑन डे 4 HCG बढ़ता है, नॉट टू वरी. If on day 7, basically HCG should decrease. If the HCG is decreasing, nothing to be given. But if the drop is less than 15%, all this they will not ask you. On day 7, okay, then you can give one more dose of methotrexate. Totally 3 doses of methotrexate can be given. Okay, max 3 doses. So all this will not be asked to you, but first you give only one. Okay, weekly. पहला एक ही देंगे, सिंगल डोज. Okay, single dose MTX, and on day 7, okay, day 7 we will see the HCG level. So if day 4 it is rising, no problem. Day 7 pe if they tell you that the HCG has not decreased, then you can repeat. Okay, is this understood to all of you? So at your level, remember that HCG should decrease. If on day 7 there is no decrease in the HCG, then you can repeat the methotrexate. Okay, is this understood to all of you? So please keep in mind that here, since it's a stable patient and HCG level bhi dekho, it is only 1500. Okay, so 1500 hai, so I will definitely A, B, C, to methotrexate. Now, yes, anybody, what is this? Again, short MCQ, total confusion among the student. So every weekly you keep on repeating. If it is going down, nothing to worry. Yes, this is a PYQ. All of you correct. Yes. So please understand this. कि sir simple है कि because of the previous twins, your gravida and parity will not change. Okay, is this understood to all of you? So sir, patient is pregnant for the second time, and remember the previous twins. So patient is okay. Okay, so please understand this, that patient is, when first time twins, she is only para 1. Okay, she is only para 1 after her first delivery. Okay, and now she has two babies. So P1 L2 means what? Jaise P1 L2 aaya, you have to know that this is a twins delivery because there are two babies, and suppose both babies are healthy and living. Okay, and now when the same patient becomes pregnant again, she will become G2, whether it is twins or triplets also. So P1L3 tells you it is triplets delivery. All the three babies are alive. Suppose all the three babies are alive. Okay. Okay. Yes, definitely. Okay. So therefore the patient is just G2P1. Okay. She is not P2. She is not G3. She is not G3. Take home message खाली एक ही है कि let it be previous twins or triplets or quadruplets, your G and P status will not change, and therefore G2, P1, L2. Yes, L2 if both the babies are living, G2, P1, L2. Okay, that is the answer. चलो, ये क्या है? किसने देखा है अभी मूवी? Okay, good news, bad news. Okay, but don't see movie now. See the movie after your exam is over. Okay, Tripti Dimri and Vicky Kaushal and this. Okay. Yes, ये क्या है? Beta, sometimes HCG rises on, therefore we are not bothered about it. Okay, it's not considered because you have to wait till 7. Okay, Parth, we repeat on 4th day rise hota hai, not actually we many time we don't check also on the 4th day. We check it directly on the 7th day. Okay. Okay. Yes. So what is this is, please pay attention, that a patient is having twins delivery. Husband asked for paternity testing. One baby found to be his, one not found to be his. Okay. So ये क्या गड़बड़? Okay, कुछ तो गड़बड़ है. Remember simple, my dear student. Superfetation is not possible in humans. Okay. Superfetation means what? Okay. Okay, superfetation is what? That sir, patient is having two ovas released in different cycle, which is not unfertilized. That means that is superfetation. याद रखेंगे fetus के ऊपर fetus. So that is not possible in humans. Two ovas are released in the different cycle. That means sir, one egg and one sperm already pregnant. Baby started to grow, and then again there is next ovulation and next baby getting implanted. So two babies will be there, but a gap of 1 month. Sorry, that is not possible. And the answer over here is superfecundation, because sir, there are two ovas released in the same cycle but fertilized by different acts of coitus by the same or different partner. So same partner होगा तो पता ही नहीं चलेगा, but different partner होता है. That means what? In the night the wife has sex with the husband, morning husband leaves, and then the neighbor enters. ओके, सो इसी लाइन पे पूरा मूवी बना दिया करण जौहर ने, धर्मा प्रोडक्शन ने, सुपर फीकंडेशन, एंड दैट इज द आंसर. Yes, that is a yes beta KK, that is in the book. In our PG textbooks there is a photograph where two babies photo is given, one is white, one is black. Okay, it does not matter whether you are black or white, no racism, but yes, just by the way, yes, the photo was there and therefore husband had a doubt. Okay, so two ovas, same cycle, but different acts of coitus, that is superfecundation. Okay, again, when there is confusion, patient is having lactating mother, so the LMP is not known. Patient has conceived in lactational amenorrhea. What is the best way What is the best way to calculate the gestational age? Okay. Gestational age, whenever there is a confusion, the first trimester sonography, very good, this is called as dating scan. Again, dating scan is not when you take your girl. We get such answers in Viva. Okay, sir, during dating period, boyfriend will do girlfriend scan, girlfriend will do boyfriend scan. So that is not dating scan. So scan done during dating period is dating scan. No, dating scan is to date the pregnancy, and therefore crown rump length done in the first trimester is the most accurate. Okay, and that is the most accurate. Best पूछा है, best, yeah, of course the most accurate to get the gestational age. Okay, बेटा पल्लवी D नहीं है. Abdominal circumference is mainly for IUGR. It is the best for IUGR. Abdominal circumference से पता चलेगा baby is small. So crown rump length by USG in the first trimester dating scan is the most accurate for dating the pregnancy when the LMP is not known. Okay, is this understood to all of you? Moving on. Yes. Anybody? Chalo. What is the diagnosis? What is the diagnosis? What is the diagnosis? We have got a patient with infertility, dyspareunia, dysmenorrhea. क्या है हमारा? क्या है हमारा? ये DID. DID is Dance India Dance. Clap if you feel happy is my mnemonic for endometriosis. Okay. Dance India Dance. That means your dysmenorrhea, infertility, dyspareunia. Okay. DID. ये I, and therefore this is endometriosis, and very important in endometriosis, laparoscopy is the investigation of choice. And what will I get? Is this subserosal fibroid? No. Will I get Asherman? No. So this is chocolate cyst and adhesions in the pouch of Douglas, which are features of endometriosis. Virgin MCQ surely coming in the future. And quickly, can anybody tell me, when I put in a telescope, when we put in a telescope in a patient of endometriosis, what all will I see? क्या क्या दिखेगा हमें? Tell me three features. Tell me three features of endometriosis. Okay, so in endometriosis, of course I will get a chocolate cyst. Of course I will get a chocolate cyst. And what else will I get? Sir, we will get blue lesion, blueberry, red raspberry, purple raspberry, all these fruits, fruit salad. Okay, fruit salad. So blue, purple, raspberry, all this you get, and you also get adhesions. And yes, we also get very good matchstick burnt appearance or gunpowder. Okay, gunshot appearance. We get black spots. Okay, so black color gunshot, matchstick burnt spots, all this laparoscopy, and you also can do the simultaneous treatment. Okay, so chocolate cyst also we get. Yes, powder burn spots. Okay. Now, what is this very important MCQ? Do not make a mistake. Do not make a mistake. 47-year-old patient. So she is in the perimenopause. And what is the rule? Please pay attention. कि perimenopause patient है with having menorrhagia for 3 months. What is the line of management? ओके, सो प्लीज अंडरस्टैंड दिस। इसमें जो ट्रिक है वो ये है कि सर 2 सेंटीमीटर एंटीरियर वॉल फाइब्रॉइड, सच अ चिंटू फाइब्रॉइड is not going to cause menorrhagia. Is this understood to all of you? And therefore myomectomy is not the answer. You have to think that sir, there is something wrong with the lining. There could be something wrong with the lining of the uterus. And very good. And never directly do hysterectomy. Very common mistake. Never directly. Why never directly hysterectomy? Because please understand this, that whenever I have a patient who is in the perimenopausal age group, क्या रूल याद रखना है? नो बेटा गनर्स, हिस्टेक्टमी नहीं, नेवर डायरेक्टली हिस्टेक्टमी. DNC is the answer. Clap if you have learned something new. Why? Because whenever there is any patient who is in the perimenopause, I need to rule out endometrial hyperplasia and endometrial cancer first. Is this understood to all of you? Because why? Suppose directly I remove the uterus, directly if I do hysterectomy and the report comes out to be cancer, you have done an inadequate surgery. So remember this, my dear student, very good Dr. Jain, that whenever there is a perimenopausal patient, either I will do a DNC first or a endometrial biopsy or even hysteroscopy and biopsy. Why? To rule out endometrial hyperplasia, endometrial cancer first, and then only proceed for the treatment. Yes, so therefore the answer is DNC I will do. Because clap if you feel happy, write down this word. Histopathological examination of the endometrium is mandatory. Okay, हिस्टोपैथ पहले करना ही है. Yes, thank you for your love and appreciation. Okay, कि हिस्टोपैथ पहले करना है and then you decide. Never directly give hormones. Hormones you may give later on, but first do a endometrial biopsy or a DNC and never directly proceed for hysterectomy. Then thumbs up. Is this understood to all of you? Then only I will proceed further. Yes, what is this image? अभी बता दिया कि ये है आपका laparoscopy. You are seeing the uterus. We are seeing this ovary. We are holding the fallopian tube. And what is all this? Meta same, even if the age is 60, so 60 तो और the more. Okay, Virendra Pratap, 60 मतलब postmenopausal lady. So postmenopausal lady also, if she is having bleeding, then again we have to do DNC only first. Okay, basically histopath biopsy. Yes. So what is this blue color? Blue hai pani, pani. Everybody starts jumping in the OT. What is this blue color dye? Sir, this is the methylene blue dye, which is again a Virgin MCQ, surely coming in the exam. This is laparoscopy chromoperturbation, and it is, please keep this picture, and this is the best investigation for tubal patency. Okay, best investigation for tubal patency, confirmatory या gold standard for tubal patency test. Okay, it is the inside the uterus. We never put methylene blue dye. Okay beta, so hysteroscopy के साथ we don't we put the methylene blue dye inside the uterus only, but we are checking out whether it is coming out of the fimbrial end or not. Okay, so with hysteroscopy we don't combine methylene blue. Laparoscopy chromoperturbation done with methylene blue, that is it. You push the dye through the cervix. Okay, so the dye is pushed through the cervix only. Blue color dye डालते हैं, blue color dye डालते हैं, and we are checking whether that blue color dye is coming out from here or not. Okay, is this understood to all of you? This is the tube. Okay, so this is the tube of the patient, and we are checking whether the blue color dye, we are putting a telescope from above. Okay, and we are checking whether this blue color dye which I put is coming out from here or not. इसको बोलते हैं spill of the dye. Okay, and that is this. The common anomaly, most common anomaly in the baby of the diabetic mother. Please don't make a mistake. Many students directly mark A as the answer. Okay, the MCQ is the most common anomaly in the baby of the diabetic mother is your VSD. VSD is the most common. Caudal regression is the most specific. Most specific. It is not most common. अगर most specific पूछा तो वो आंसर देना है. Okay. Is it clear? Okay. Is it clear to all of you? Is it clear to all of you? So the most specific, and TGV is also very specific cardiac, but the most common is VSD. Okay. Yes. So the most specific anomaly on the baby of the diabetic mother is the sacral agency, also called as caudal regression syndrome. VSD is the most common. Okay. Anencephaly also we get in the baby of the diabetic mother. Okay. Moving on. All are tocolytics except. So here I just wanted to teach you tocolytics matlab uterine relaxant. Okay. So tocolytics matlab uterine relaxants. And therefore please understand ritodrine, nifedipine, atosiban and magnesium sulfate all have tocolytic property. Very good. I just now told you I wanted this MCQ just to teach you what is carbetocin. Sir, carbetocin is a oxytocin derivative. It will cause more uterine contraction, but it is heat stable and carbetocin. Okay, atosiban is a new drug. Atosiban is also a, what is atosiban? Oxytocin antagonist. So don't keep mistake all this is pharmac MCQ also. Keep in mind it is surely likely to be asked. Okay, and before we proceed further, still few more MCQs are there, but all of you quickly do subscribe to the YouTube channel and also go and hit the like button on this and also follow me on Insta. And all those who haven't, I'm telling you, this is the last chance. Do not miss out this opportunity. Just in 1 day time you will become master of OBGY. Download the OGGuru app, get in touch with me on the phone number, and all of you can go for rapid revision MCQ discussion pack. Last chance before the NEET PG, and within 1 day you can revise the entire OBGY under my guidance. And all those who are giving the upcoming exams next year, 6 months after that, 6 months, 12 months course also available. Very simple MCQ, M cells criteria all except. Okay, so M cells criteria. Beta, Criveri, fetal position also I've discussed beta. Okay, you can check the image based MCQ also. Criveri in the Criveri. Okay, in the they have given explain about that, so I didn't want to overlap. Okay, so you can also check out the rapid revision MCQ video on the YouTube channel. Just there, check out the rapid revision theory video. Okay, theory video also please check out. Okay, theory video is there entire 3 hours. Okay, before I proceed further, just one thing, we have also had a 3 hours complete revision. This video is already crossing more than 18,000 views. 3 hours detailed. There is a rapid revision theory. So this is, today is MCQ. This is a theory video. Okay, which is free on YouTube. Okay, and beta Criveri also check out the video about images also when Sikai fetal position. Okay, yes. So great white vaginal discharge, M cells criteria for diagnosis of bacterial vaginosis, positive whiff test and presence of clue cell. Very good. Okay, sir, vaginal pH is not less than 4.7. Only this one sign is changed. Vaginal pH more than 4.7 hota hai. Okay, these are the great white discharge, positive whiff test and presence of clue cells. And what is the drug of choice for bacterial vaginosis? Anybody? And remember, partner treatment not required. Partner treatment not required. Metronidazole. Identify this image based MCQ. This is, they will tell you, it's an ultrasonography of the uterus, and within the uterus what are we seeing? Sir, we are seeing multiple fluid filled grapes like particle. Grapes. ये सब छोटे. ये सब क्या है? This is the uterus, and the whole uterus is your studied, and this is the famous snowstorm appearance. Very good. And therefore complete H mole or V mole is the answer. Complete vesicular mole is the answer to this MCQ. Do not make a mistake. And this is our next famous MCQ, shock. Now, shock in early pregnancy. 20-year-old presents with 2 months and shock. What is the diagnosis? UPT positive. This is ruptured ectopic pregnancy, shock in early pregnancy, ruptured ectopic, unless proven otherwise, definitive treatment, sorry sir, methotrexate not. And in shock, laparotomy better, laparoscopy can also be done, but salpingectomy, not salpingotomy, not salpingotomy. Okay, salpingotomy अब नहीं करते हैं. Remember, don't feel sad that you are cutting off patients one tube. One tube is enough to cause population explosion. Yes, salpingectomy, very good, is the gold standard surgery. Is this understood to all of you? So laparotomy and salpingectomy. In quick hands, even laparoscopy can be done nowadays, but it is your ruptured ectopic. Okay, so both ectopic management I have discussed for all of you. Again, a very important pharmacology MCQ. Patient is taking her oral anticoagulants. Okay, oral anticoagulants which she has not stopped at 10 weeks. Which is that oral anticoagulant? Warfarin. So pharmac MCQ, warfarin से क्या होगा? warfarin से क्या होगा? Yes, sir, warfarin से होता है fetal Conradi syndrome. And Conradi syndrome, clap if you feel happy. Conradi starts with letter C, and therefore the problem also starts with C, and C, central nervous system and cartilage gets affected. You get nasal hypoplasia, chondrodysplasia, and optic atrophy, blindness, baby cannot see. Okay, renal problem is with ACE inhibitors. Conradi syndrome, CNS cartilage. न्यूरल ट्यूब डिफेक्ट, न्यूरल ट्यूब. बेटा मिस्त्री अभी बता, एंडोमेट्रियस टायर्ड DID, डांस इंडिया डांस. ओके, एंडोमेट्रियस टायर्ड DID, जस्ट गो बैक एंड चेक द MCQ. ओके, yes, cartilage, chondrodysplasia, perfect. And neural tube defect is with anti-epileptic drug. Okay, anti-epileptic drugs, neural tube defect. Vesicular mole, what is the treatment of choice? Vesicular mole, 28-week size, vesicular mole, what is the treatment of choice? Anybody? So please understand this, vesicular mole, whatever may be the weeks of gestation, whether it is 24 weeks, 26 weeks, 32 weeks, 16 weeks, please understand, vesicular mole does not come under MTP purview. It's just to fool the student. MTP not allowed नहीं है, as patient is 28 weeks, no. So MTP का कोई connection नहीं है. And please don't do hysterotomy. Okay, and never induce labor. Okay, is it clear to all of you? Hysterotomy is you'll have to go to jail. Okay, that means cut open the uterus. Yes, so in remember, vesicular mole, suction evacuation is the treatment of choice, whatever may be the weeks of gestation given to you. And after sucking out, we monitor the HCG levels. HCG should keep on dropping down. Okay, is it clear to all of you? So whatever may be the size, we have to go for suction evacuation only. Is this understood to all of you? Yes. A new style of asking question, ध्यान से सुनेंगे, do not directly mark. What is the true state? Consider the statements regarding uterine leiomyoma, matlab fibroids. Okay, fibroids. Which of the above statements are correct? Anybody? So yes, fibroids are highest between 35 to 45 years age. Yes, I agree, definitely. And more common in nulliparous, okay, those who don't have babies or delayed babies. Nowadays क्या हो रहा है कि सर this life is for me and my husband to enjoy, जिंदगी ना मिलेगी दोबारा, बच्चे देखेंगे अगले जन्म में. So all those who don't have babies or less babies or no babies are going to have more fibroids. Okay, they are also called as ding couple. Okay, double income no kids. ये by the way, okay, ding couple, double income no kids, husband wife both मजा मस्ती time pass world tour, but we don't want babies. Okay, we'll adopt a dog. Okay, so definitely nulliparous. And yes, all fibroids do not require treatment. So many fibroids are there. You just see if the uterus is here, there is a chin to 2 centimeter, 3 centimeter, you do not treat. Only symptomatic fibroids require to be treatment. And yes, please keep in mind that when I give GnRH analogs, there is going to be a shrinkage in the size of the fibroid, but it will grow back after the drug action is over. And therefore very good, all of you, all 1 2 3 and 4 all are correct, all are correct. Okay, all correct. And therefore fourth is the option number, fourth is the answer. 1 2 3 for all of it. Okay, so this is a new style of asking question. Don't get hassled, you'll still get it anyways. Okay, just keep in mind, read the option which of the above statements are correct पूछा है. Okay, can anybody tell me one more drug which decrease the size of the fibroid? What are the drugs which are used to decrease the fibroid size? Just by the way, extra information. Okay, so GnRH analogs, yes, we give. Danazol we are not giving. Mifepristone has also been shown to decrease the fibroid size, and ulipristal also. Yes, ulipristal also. Okay, and danazol theoretically, yes. Okay, danazol we don't use nowadays, but all. Okay, all these are drugs which are going to decrease the size of the fibroid. And progesterone, do not forget progesterones. Okay, 1 2 3 4 5. Progesterones also decrease the size of the fibroids. And as a revision, abhi sikhaya, abhi ka abhi, chalo, I want all of you to get this correct. I want all of you. Yes, excellent, all of you. So this is the condition and these are the investigation. For which condition we are going to do which investigation? Endometriosis के लिए laparoscopy is the investigation of choice. ठोको ताली, clap. Asherman syndrome, hysteroscopy. So 2A, 2A, 2A. Chalo, chalo, chalo. But endometriosis 1B, 1B, 1B. And ovarian torsion के साथ I told you color Doppler 3C, 3C. It is not 3D and 4 is not C. So this is out. And yes, all of you know better. Okay, and for fibroids, normal ultrasonography is the preferred. So 4D. Okay, so 1B, 2A, 3C, 4D. This is the answer. 1B, yes. 2A, 3C, torsion, color Doppler, definitely I have discussed this. And fibroids के लिए plain ultrasonography is more than enough. Okay, so and all of you do hit the like button and do subscribe to the channel, and all of you please download the OGGuru app. That is, I think, all our this, and do follow me on Insta, and we are going to keep on putting MCQs every day, and the annotated PDF of all this session will be available on the Telegram channel also. Okay, and definitely get in touch with me on phone and WhatsApp me on this number. And as I said, those who are giving the NEET PG, you can revise the entire OBGY just in 4 to 5 hours time. Gynec MCQs in 4 5 hours time. Obstetric MCQ in 1 day. Will become champion of OBGY is my guarantee. Please share this video with all your friends and colleagues, and I request all of you that you can of course download the OGGuru app, and also please check out on the YouTube channel. There is, as I said, rapid revision 3 hours theory video. That also please all of you check out. And also you can check out the image based questions also I have put. So lots of video on YouTube is already put, and I hope all of you. Beta, name what, Dr. Jain? Name of what? Name of the app? OGGuru app. Okay, Dr. Jain, OGGuru app. This is the link and you will get it. And beta, you can give it for long time, 2, 3, 4, 5 years. You can give it long term. PCOS will be required. Okay, so I wish all of you best of luck for coming in today. Please do share this video, and all of you, just my trip is, and also do check out one video where I have given the list of important topics. Okay, list of important topics also I have given to all of you. I hope all of you had a great time. Thumbs up in the chat box, heart and OG in the chat box. Wishing you all the best for the upcoming examinations. All of you will do very well, and do share this video with all your friends and colleagues. I hope all of you had a great time. It was great teaching all of you, and see you soon. Thank you very much for all your love and appreciation. That's our session today. That's our time. Bye-bye. Best of luck and see you soon. Okay, and do not forget to follow over here, and do not forget to install the OGGuru app and get in touch with me on phone and WhatsApp. Bye-bye. Best of luck. Wishing you all the best for the upcoming NEET PG examinations, and do get in touch with me on phone and WhatsApp. Thank you, all of you.